Rudiger, this is a slide you had of this beautiful shot of the Alps, and I've learned Munich has many things that are fantastic. They have great science. This was actually science from the Oktoberfest, published in the European Heart Journal just recently, and it had brilliant research that said acute alcohol consumption can trigger cardiac arrhythmias. I thought, that's brilliant. I mean, I'd never known that before, so I'll have to come back to Oktoberfest and try to see if that's so. But I am thrilled to be here. I am going to give you a few lessons from Echo. One of the things I've learned is Dr. Rudiger is much bigger than me, and he tried to exercise me to death one time. Robert, this is in Leiden at 7 o'clock in the morning, so these are my disclosures. I have nothing that's pertinent to this. So the future of mitral imaging...
Randy, can I just make a comment?
Yes, sir.
The first comment is I'm not bigger, I'm just a little bit taller than you are. But
just a little bit taller.
But the study that Randy just showed is very interesting. It's from the other university,
right?
And they actually went to the Oktoberfest and they asked. I mean, I don't know how they did it, because if you have ever been at the Oktoberfest, it's so crazy that I cannot imagine to ask a person who has 1.4 promille of alcohol in his blood to have the alcohol content determined first, and then have a little EKG. But apparently, they found enough people in a wide range of alcohol consumption and made this beautiful study.
Yeah,
I think
it's fascinating.
It's fascinating.
I mean, what they're saying is basically that it triggers, alcohol consumption triggers autonomic instability, and that's why the holiday heart syndrome is probably in there. But I thought it was very unique that they went and did that at Oktoberfest. So let me just tell you that I think the future of imaging of the mitral valve or cardiac in general is very exciting. We've got obviously some things that I'll show you quickly, 3D CT that does some really amazing things, MRI with flow, and then miniaturization. We probably will not have time for me to talk to you about artificial intelligence and some of the machine learning that's coming with very small instruments, but it's very impressive because it's designed to make the novice almost an expert in acquisition and interpretation. So that's what it's like. I think it's very important, and I've done this my whole life, is that you have to remember that an imaging technique is designed to help you or me or the surgeons or the nurses in the management of the patient. I think we do not want to get caught up in the prettiness of the picture, although there's some really dramatic imaging technology. What we want to do is to really improve the outcome of the care of the individual patient. So as a clinician, it's very important to use imaging, and echo in this situation, to help us as clinicians to help the patient, because it really is about the patient. I love what Albert Einstein said, I fear the day that technology will surpass our human interaction. The world will have a generation of idiots. The comment here means that if you do not know how to use technology to improve the care of the patient, then that's a problem. So I'm over 74. I've been doing echoes and clinical cardiology since 1975. I was fortunate to be in at the infancy of 2D echo, transesophageal echo. And so I'm going to approach this from a clinical standpoint. And I will say that currently MRI and CT are incredibly useful, and especially in transcatheter therapies. I think CT is really becoming very important. But echo has today transthoracic echo and TEE. And while everybody rushes to TEE, I will tell you that not because I'm old and because we really started 2D echo, but 2D echo can tell you, if done well, the vast majority of clinical information that you need to make decisions, while TE will really help you in the operating room and with transcatheter. So transthoracic echo, or echo in general, is important for telling what's the pathology that you've got there, the lesions that David showed, to tell the severity and determine how you're going to time the impact, and then do the follow-up. We have all of these technologies. Again, I want you to learn a couple lessons. We're not going to go through all of these, but echocardiography today with a smart clinician is your friend and is the patient's friend. An echo can determine if the heart's symptomatic, no doubt whatsoever. Unfortunately, in our country, in the United States, incomplete and inadequate echoes are very common. People rush to get one view, and they fail to see what's the right side doing, what's the left atrial size, what is ventricular function. There is new information out about quantification of MR severity, especially in secondary MR. The guidelines have changed, and the guidelines in secondary MR and primary MR, as far as quantification, are the same now. 3D TE with modeling and simulation is very exciting, but still in its infancy. But it is critical, I think, to not only surgery, but to transcatheter mitral interventions. And then I will not comment any more than this, but to tell you that AI and machine learning, artificial intelligence, is really coming. So let's take a look at this. Impressive developments in 3D TE, no doubt whatsoever, with modeling, where you can begin to do annular simulation, annular sizing. You can look at aortic mitral angles. You can look at all of these things. But 2D echo, I think, and not just because of my age or where I began, because I did begin at the infancy of this, is critical to making decisions. You can obviously see whether you've got a flail posterior leaflet, patient in AFib, big LA, torrential mitral regurgitation, or you've got an inferior posterior aneurysm with a classic ischemic mitral valve that's not only has severe MR, but is beyond operative intervention with annuloplasty, and this patient needs to have a mitral valve replacement. Also remember that transthoracic echo with simple peristernal views can tell you about the rheumatic valve on the bottom right, or on the next complex, as you'll see here, if this thing will advance for me, that it will show you in this particular situation that you've got where it looks like you've got MR that's coming from the anterior leaflet and is directed posteriorly. Notice, if you look closely, it's not coming from the commissural edge. It's actually an isolated anterior cleft. So there's tremendous amount of information that we have available to us. As Rudiker mentioned, as Yuki has shown, one of the things I thought about early on is that echo is going to tell you whether the heart's symptomatic. Tyrone David has this great slide. This is Noah's Ark, and the dinosaurs are being left as the Noah's Ark sails away with the flood there, and the dinosaurs, oh crap, was that today? If you wait for LV enlargement, LV dysfunction, AFib, and pulmonary hypertension, then restorative surgery is not going to be in the cards. And so if you see those, you know that the heart is symptomatic. So as Yuki showed, when I thought about triggers, and David asked me to give this talk some years ago, is that for restorative surgery, all of these are really too late. And the guidelines in the U.S. are changing, as I'll show you in a minute. But I look on transthoracic echo at many things. I look at not only the etiology and the severity, but I look at the size of the ventricle and its function, not solely with EF, but I'm looking now at global longitudinal strain. I look at the size of the LA. I look at resting and exercise pulmonary hypertension. I've been a proponent for years of exercise testing in the quotes asymptomatic MR patient or the asymptomatic AS patient, because it really tells you how the heart is tolerating that lesion. And so all those are important. We know that there is data, although Yuki is correct, we don't have a lot of randomized trials, that early surgery done by experienced centers and experienced operators, and that's the operative, really is going to be associated with improvement and overall longevity of life and quality of life. So picking those patients up early is very, very important. I was chair of a big ACC committee that looked into what were the gaps in mitral regurgitation management, and one of the biggest gaps we saw is patients were not being referred early enough. 58-year-old male, asymptomatic in 2014. According to his physician, he's got torrential anteriorly directed MR. He's got a little isolated cord. His LV is big, end systolic is 4.2. He's got torrential MR with a blood pressure of 137 systolic. His ERO was big, and his right-sided pressures, even though this is not a good tracing, were almost 50. So he's got guideline criteria. Then his physician opted that he said he was asymptomatic, don't send him for surgery. 2 years later, he comes back, his MR is worse. While his EF is still the same, what we did is did global strain on him, and I'll show you this in just a second. His global longitudinal strain is very abnormal. In global longitudinal strain, you're looking at the amount of shortening of the ventricle from apex to base. The more negative it is, the better the ventricle is. So as you get into a global strain of less than minus 21, so in this particular situation, less than minus 19, that ventricle is not as good as a 65% EF. That ventricle's been damaged. And look at his ERO, it's now up. So exercise echo and global longitudinal strain are two things that I would challenge you to become very proficient or get your cardiologist to be. And exercise duration and exercise symptomatology and exercise treadmill testing is extremely important. Big anteriorly directed jet, he's got isolated chordal rupture to P2, his atrium is big. This particular situation, his resting right-sided pressures were 37. I put him on the treadmill. He did only stage 2 of the Bruce. He became very symptomatic, and his right-sided pressures went up into the 80s. Here he is immediately post, and there is his right-sided pressures. He's not asymptomatic because his heart's not asymptomatic. So that's very, very important. The other thing I just quickly mentioned to you is this global longitudinal strain. There have been some good papers out. This was a paper that came out of the Cleveland Clinic. Mark Gillenoff was the second or third author there. And what these authors found is that if you'd had stress echocardiography and you showed reduced exercise capacity, according to age, and worsening LV global strain, that had independent prognostic implications. So again, global strain is very important. A normal global strain is anything greater than minus 21. Once you start falling off and get into this range, then you're losing years of quality of life, even if you repair the patient. So think about those. We'll spend about another 5 to 10 minutes, and then I'll finish up. The inadequate echoes, unfortunately, I don't know about in Germany or Europe, but in the United States, transthoracic and TEs are not complete and are missing information. Again, from our study that they did for the ACC, we found that there were many things. Not only were patients not being identified early enough, but the quality of imaging was very variable and was often inadequate. And in fact, in a large group of echoes that we looked at to see if it had all the parameters that you would need to judge not only the presence of mitral regurgitation, but the etiology, its severity, and prognostic information, the quality of echoes was lacking in at least a fourth, in some situations 2/3. It is also very common in our country, and hopefully not in your country, that secondary MR is often read as primary MR. This was a gentleman who had chronic AFib, and this was read as anterior leaflet prolapse. You know that this is a classic restricted and retracted posterior leaflet. And so, again, quality of echoes, it's imperative that we instruct our cardiologists and our echo colleagues to really push for excellence in their interpretation and performing. So let's look quickly at some information on secondary MR. And as I mentioned earlier, there is new information. Bill Zogby, an esteemed colleague, past president of the ACC and the American Society of Echo, and many colleagues both in this country and abroad looked at this and have revised the guidelines so that the guidelines for severe mitral regurgitation by ERO now are the same for primary and secondary, but obviously regurgitant volumes for reasons of the pathology encountered are a little bit less. So there is no more in this country in our country of having different EROs. So again, we look at that. The authors also emphasize that color Doppler is nothing more than really a good way to begin to look at the severity of MR, but remember that it is incredibly sensitive to gain. You can dial a leak in or you can dial a leak out. It's also sensitive to what's called the Nyquist limit. Here's a low Nyquist limit. It looks like you've got torrential MR, but a higher Nyquist shows it's not the case. And then transducer frequency influences that. So a transthoracic echo versus a TE changes it. So you have to be aware of that. And then we really have to try to push for quantification. And there are many ways of doing that. Three-dimensional PISA looks very promising. And there is some good technology coming along that's being used now in transthoracic that allows you to begin to do regurgitant volume calculations from echo. by looking flows out the LV outflow tract and then across the mitral. And that's coming, and it looks very promising. If I'm in doubt, I'll get an MR. I like MRI a lot for regurgitant volumes and regurgitant fractions. And then let's finish up by looking at a couple things. Secondary MR, again, your transthoracic tells you a lot. Here's a thinned out inferior posterior wall with an aneurysm. Here's a giant pseudoaneurysm, and a classic where you see retraction, especially in the medial aspect of the mitral valve, or another secondary MR and a hypertrophic infiltrative mitral valve. So transthoracic can tell you a lot. David Adams loaned me this slide. He used it years ago of looking at when you're trying to think about your surgical approach to secondary MR. Are you going to do valve replacement or annuloplasty? We know from the literature, I think, Robert, you and Professor Dion and others have pioneered the way of looking at this, that from just transthoracic echo, you can look at size of the ventricle, tinning areas, coaptation distance, things like the distance between the papillary muscles and the so-called posterior lateral angle, and there's lots of information in that will tell you that this patient would not benefit and in fact should probably not have a mitral valve repair, but would be a candidate for a replacement, as this gentleman that I showed you earlier. Tremendous. This gentleman underwent a mitral valve annuloplasty, which he should not have had, and ended up obviously with recurrent significant mitral regurgitation. 3D TE offers tremendous information. Just a caveat to that is that while this from Roberto Lang showing this nice paper of a cleft and beautiful shows, remember that 3D TE does not have excellent resolution. This is what a ruptured cord looks like on a 2D. This is what it looks like in 3D. So everything looks bigger and blobbier, if you will. So just be aware of that, especially with looking for fine details. The other thing that I find is very common, and it is sometimes problematic, is that you often have what's called dropout. This looks like there's holes in the non-coronary left and right coronary cusp, or here in the left cusp. And this is an example that I'll show you of a real hole and an artifact hole. So you have to be aware. This was an unfortunate situation where a septal myectomy was done and they perforated the anterior leaflet at the base. And this is, if you look here on the surgical view, this looks like a hole in the 3D TE. And in fact, when you can turn on simultaneous color, sometimes it helps you out a lot. This is from the atrial surface and the ventricular surface. That yes, that does look like a rent in the valve. But look at this person, okay? And this is not at all uncommon. If you look at this, you think, gee, is there a real artifact there? Is this a cleft? These are all echo dropouts. And sometimes it's very, very hard to tell the difference. So just be aware of that 3D TE does not have resolution and it suffers from dropout. But saying that, there are tremendous advances that have been made in modeling, and I think that's very important. And then finally, let me just show you one thing here, and then I will finish, because I think this is really important, is that there's no doubt that as we move into the future, okay, and the future is here, and that's the future of mitral valve disease and treatment, we're going to see, as you all have been pioneers in minimally invasive techniques, but also the techniques, obviously, with the MitraClip, the techniques with neocord and harpoon, and then the techniques with transcatheter mitral valve replacement. Very, very exciting, very much in its infancy stage. But in this situation, two imaging techniques are going to be critical. I think the imaging technique of CT with modeling and simulation is extremely important. But we have no doubts whatsoever that TE done well is going to be the guide for you in the interventional or hybrid OR. In this particular situation, this is the Medtronic Intrepid valve, and you can see that it's very useful for helping with the implantation. So the lessons I've learned from echo is that it's an extremely useful technique, going to be more useful in the future with miniaturization of instrumentation. There's no doubt in my mind that each of you will have an echo stethoscope. In the not distant future, there are some very, very small, very powerful machines in development. But it's important to use it as a clinician designed to help the patient. And if you do that, then it's very powerful. The newer imaging modalities of CT, three-dimensional TE simulation, and MR play an incredible role. But the lesson I've learned is an excellent echo, transthoracic echo, if you will, attached to an astute clinician is your friend. Thank you very much.